Huntington's disease is a rare, dominantly inherited neurodegenerative disease that is characterized by CAG trinucleotide repeat expansion in the Huntington gene on chromosome 4. One is usually diagnosed with this due to family history or a positive genetic test and the onset of motor disturbances. Onset of the disease is usually around 40 years of age, though higher repeats of the triplet on the Huntington gene have been correlated with earlier age of onset of the disease. Those with Huntington's disease will have a higher than usual number of CAG repeats. Those with between 36 and 39 repeats have been shown to have reduced penetrance, while those with 40 or more repeats have 100% penetrance and the person will have the symptoms of Huntington's. The phenomenon of anticipation explains why the age of onset tends to decrease, as it is inherited through successive generations, especially when passed down the paternal line, due to the instability of the CAG repeats combined with greater variability and larger repeat sizes seen in sperm. The mutant Huntington causes neuron dysfunction in the basal ganglia and eventually death through varying mechanisms. The dysfunction results in disruption of proteostasis, transcription, and mitochondrial function, and one major contributor to the brain damage is the direct toxicity of the mutant Huntington protein. The disease is characterized by general shrinkage of the brain, enlargement of the lateral ventricles, degeneration of the striatum, the caudate nucleus and putamen, and specifically the loss of efferent medium spiny neurons, which creates motor disturbances. Common symptoms seen in those with Huntington's disease include motor disturbances, for example, hyperkinetic symptoms such as chorea in the early stages, and hypokinetic symptoms such as bradykinesia, dystonia, balance, and gait disturbance. There are also cognitive disturbances such as impaired emotional recognition and processing speed, and neuropsychiatric disturbances such as apathy, anxiety, irritability, depression, and obsessive-compulsive behavior. Death in those with Huntington's will occur usually within 10 to 20 years of their diagnosis, and this is commonly due to aspiration pneumonia or suicide. Management of this disease can only involve symptomatic treatment, as no cure is available. Despite the simple genetic cause, the specific mechanisms of pathogenesis are highly complex. Neuroleptics and tetrabenazine are usually used to treat chorea, but this does not increase the lifespan of one with Huntington's. Optimal management will usually be a multidisciplinary approach. This involves the patient seeing a combination of physicians, nurses, physiotherapists, speech therapists, dietitians, and other healthcare professionals to optimize quality of life, treating the specific needs of the patient through the course of their disease. One particular technology that is helping to progress our understanding of Huntington's disease, as well as a possible treatment option, is stem cells. Stem cells hold huge potential not only as an approach to therapy to manage Huntington's disease, but they can also be used to investigate both molecular and cellular mechanisms within the HD pathophysiology. This research would be done through cell reprogramming and gene editing technologies. An example of how stem cell technology could be used as a treatment is as a transplant following the ablation of glial cells. Glial cells are non-neuronal cells whose role is to support and protect neurons. In a person who has a wild-type Huntington allele, they maintain homeostasis as well as forming myelin. But when these cells are affected by the mutant Huntington, these cells lose normal function and gain neuropathic phenotypes. Glial cell dysfunction contributes to the Huntington's disease pathology and has been shown to occur in the early stages of the disease in pre-symptomatic patients. Studies have shown that the elimination of these cells can rescue various aspects of the disease pathology, as well as improve the patient's motor and cognitive performance. Following glial cell ablation, patients have been seen to have a slower decline in motor performance, increased striatal volume, reduced expression of inflammatory cytokines, and increased expression of myelin proteins. Though ablation is successful in improving symptoms, it does not rescue the motor performance completely, nor restore the brain's volume. This is where stem cell technology can come into play as a treatment. Stem cells are specialized human cells which have the ability to develop into a variety of cells such as muscle, cardiac, and brain cells. These cells, once mature, could assist in restoring lost neuronal cell processes and function and prevent further degeneration, helping to manage and treat Huntington's disease. Stem cell transplantation would work by transplanting donor or patient-derived fibroblasts that have been formed into neural precursor cells. These could then be differentiated to neural stem cells or striatal precursors before transplantation into the patient. Though promising, there are some issues that are related to stem cell transplantation, including ethical issues such as using human embryonic stem cells, and varying results in terms of graft survival, safety, and outcome. Overall, research on stem cells shows a promising option to treat Huntington's disease. For example, replacing affected glial cells would help to restore cognitive and motor function, and if transplanted in pre-symptomatic patients, can reduce any damage caused. In summary, Huntington's disease is a rare, dominantly inherited neurodegenerative disease that is characterized by 36 or more CAG repeats on chromosome 4. The mutant Huntington causes death in the basal ganglia, resulting in motor, cognitive, and neuropsychiatric disturbances. A promising treatment for this disease is stem cell technology to restore degeneration and eliminate the Huntington's disease symptoms.